Hello, my name is Victoria Lee. I'm an assistant professor in rhinology, sinus, and skull-base surgery at the University of Illinois, Chicago. I will be presenting this chapter entitled Topical Medical Therapy Delivery and Efficacy, with a focus on its applications to inflammatory sinus disease. These are my disclosures. This is the outline of the talk. After a short introduction, I'll sequentially discuss topical saline, topical steroids, and topical anti-infectives. At the end, we'll review conclusions and key points and provide suggested reading and sources. Now, the sinonasal cavity is easily accessible and therefore particularly amenable to topical therapy. Topical therapy offers multiple advantages over systemic therapy. It can be directly delivered onto the affected tissue and can achieve higher local concentrations with minimal systemic absorption, thereby reducing the potential for adverse systemic effects. The existing data support optimal sinus delivery using a high volume irrigation device, so greater than 60 to 100 mLs, and in surgically open sinuses and the head down and forward position. Topical therapies for CRS come in different flavors to address both inflammatory and infectious etiologies. In its plainest form, there's saline. Anti-inflammatories include topical steroids, such as budesonide and mometasone. Anti-infectives include topical antibiotics, such as mupirocin and tobramycin, alternative therapies, such as manuka honey and surfactants, and antifungals. Topical antifungals are not recommended for CRS without or CRS with polyps. And as the data is strong against their use, they will not be further discussed in this talk. So let's start by looking at the data on topical saline therapy for CRS without and CRS with polyps. The proposed physiologic benefits of nasal saline irrigations include improved mucociliary clearance and disruption and removal of mucus, blood, and environmental allergens. Overall, there have been 2 Cochrane systematic reviews looking at saline effectiveness in general. The 2007 systematic review included a meta-analysis and consisted of 8 randomized controlled trials. Now, these RCTs included patients with symptoms of CRS, and it is worth noting patients with both rhinitis and sinusitis. It performed multiple comparisons, pooled if more than one study was available. For the saline versus no treatment comparison, saline performed better. For the saline versus reflexology placebo comparison, both treatments achieved similar results. For the saline versus steroid spray comparison, steroid spray performed better. And for the saline as an adjunct therapy comparison, the combination therapy was better. An updated systematic review was conducted in 2016. A meta-analysis was not performed due to the identification of only 2 studies, which were quite heterogeneous. Unlike the previous review, this one only included patients with CRS. Now, in the high volume hypertonic saline versus placebo comparison, saline was better after both 3 and 6 months of treatment. In the low volume nebulized saline versus steroid spray comparison, steroid spray was better. Now, a caveat to these conclusions was the evidence was noted to be of low to very low quality. Regarding the minimum duration of treatment, Tecariello et al. Performed a study of patients with CRS, randomized to perform either traditional alkaline nasal douche, sterile seawater spray, or standard treatment. The study found that both treatment groups had significant improvement in endoscopic and quality of life scores after 8 weeks of treatment. Now, what about the question of hypertonic versus isotonic saline? The Harvey 2007 systematic review with meta-analysis also did a hypertonic versus isotonic saline comparison, which included 3 randomized controlled trials and 134 patients with both recurrent acute and chronic rhinosinusitis. The study found that hypertonic and isotonic saline achieved similar results. In 2018, a systematic review with meta-analysis was performed consisting of 9 RCTs and 740 patients with rhinitis and rhinosinusitis. This study found that hypertonic saline achieved better total nasal symptom scores, but there was no difference in disease-specific SNOT-20 score improvement. Also worth noting, hypertonic saline had greater minor side effects than isotonic saline. How about high versus low volume saline? A 2007 RCT included 127 patients with nasal and sinus symptoms, comparing high volume saline versus saline spray. It found that the high volume saline group had significantly better SNOT-20 scores and symptom frequency over an 8-week period. Now, this slide summarizes the recommendations of the International Consensus Statement on Allergy and Rhinology, Rhinosinusitis 2021, which I'll refer to as ICAR for the remainder of this talk. In CRS without polyps, the use of saline irrigation, at least 60 mL, is recommended as an adjunct to standard treatment. Duration of treatment should be greater than 8 weeks, and hypertonic saline is overall more effective, but may be more irritating than isotonic saline. In CRS with polyps, saline irrigations are an option, particularly in patients with thick mucus. How about the postoperative period? An RCT by Liang et al. Included patients with CRS who underwent sinus surgery. In the mild CRS group, it found that saline plus debridement improved symptoms and endoscopic appearance compared with debridement alone. In the severe CRS group, there was no difference. Per ICAR, saline is recommended in the postoperative period. Now, the etiology of CRS has undergone a paradigm shift over the past 10 to 15 years. The primary etiology was initially felt to be more infection than inflammation, but it is now recognized that the primary etiology is more inflammation than infection. Correspondingly, topical steroids, which target inflammation, have become highly studied. So let's look at the data on topical steroids, starting with CRS without polyps. Steroids suppress inflammation via a variety of mechanisms. They reduce circulating leukocytes and inhibit pro-inflammatory transcription factors, arachidonic acid metabolites, histamine and leukotriene release from basophils, neuropeptide-induced inflammation, and lysozyme release. They also decrease vascular permeability and inhibit glycoprotein release from some mucosal glands, thinning mucus secretions. Now, standard delivery refers to sprays or metered dose topical steroid solutions that are approved by the Food and Drug Administration for nasal use. Now, there are 3 high-quality systematic reviews with meta-analyses that address the use of these sprays in CRS without polyps. The most recent, Chong et al., included 4 RCTs and noted only a slight improvement with steroid sprays for the general health subscale. Otherwise, no differences. Sidvons et al. Pulled symptom scores for 5 RCTs and found a significant improvement with steroid sprays, with no significant heterogeneity between studies noted. Finally, Kalish et al. Combined results from 5 RCTs and concluded there was no significant benefit with steroid sprays, although there was significant heterogeneity between studies. So with this data, ICAR concluded in CRS without polyps, topical steroid sprays are an option, particularly if primary symptoms are that of rhinitis. Now, overall, the literature is less robust, although minimal, though consistent improvements are seen in both surgical and non-surgical patients. Now, non-standard delivery refers to off-label therapies, such as high-volume topical steroid irrigations, which are designed to deliver a higher volume and concentration of steroid. Grayson et al. Conducted a systematic review, including 11 studies. Overall, it concluded the best outcomes with large volume, low pressure devices in the postoperative setting without significant adverse effects. 2 RCTs have been published relative to this topic as well. In a 12-month follow-up study, Harvey et al. Compared large volume mometasone irrigation with mometasone spray in postoperative patients. Now, steroid irrigations improved patient-reported symptoms, radiographic scores, and endoscopic appearance as compared to the steroid spray. Tate et al. Compared budesonide irrigations with saline alone in patients with primarily CRS without polyps, administered over 30 days, and concluded improved subjective and objective outcomes in the budesonide group. However, the results did not reach statistical significance. So with this data, ICAR concluded in CRS without polyps, non-standard delivery of topical steroids is recommended in both postoperative patients and is also an option in non-surgical patients. As far as use of exhalational devices and atomizers, this is an option in CRS without polyps. Now let's look at the data on topical steroids for CRS with polyps, which is overall much more substantial. Starting with the data on the standard spray delivery method, the most updated Cochrane review by Chung et al. In 2016 included 14 studies of patients with CRS with polyps. It found improvements in polyp and symptom scores with the quality of evidence graded as moderate. Now, notably, a systematic review on the use of twice-daily dosing of steroid sprays in the setting of CRS with polyps was also performed. The authors' conclusions were that there was a preponderance of evidence favoring twice-daily dosing. So based on this data, ICAR has recommended steroid sprays before or after sinus surgery in CRS with polyps, with a consideration for twice-daily dosing. Looking at non-standard delivery methods of irrigations and atomization, one randomized controlled trial compared steroid irrigation with steroid spray and found irrigations to be superior. 3 other RCTs compared steroid and saline irrigations and found variable results. Furthermore, 3 RCTs compared steroid atomization and steroid spray and found atomization yielded better clinical outcomes overall. Another newer non-standard delivery method is the exhalation delivery system, the most commonly studied under the trademark name EXHALATION. Now, this is a breath-actuated device delivering fluticasone to the nasal cavity via nasal device. The Navigate 1 and 2 studies compared EXHALATION to placebo and found EXHALATION to be consistently better. We do, however, need more studies, more relevantly comparing EXHALATION to other steroid delivery methods. In summary, regarding non-standard topical steroid delivery for CRS with polyps, there's a strong recommendation for steroid irrigations. Exhalation delivery is an option. An atomization delivery method is recommended. For both the steroid irrigation and atomization non-standard delivery methods postoperatively, ICAR stated they should be offered in moderate to severe disease, or if disease and symptoms are not controlled with standard delivery methods. Steroid sinus implants offer a longer-term topical delivery method. The PROPEL family is one such type, acting as a stent or spacer that releases steroid continuously. It is FDA approved for CRS with polyps and is designed to be placed at or around the time of surgery. There are three types: the regular, which is designed for the ethmoid sinus; the mini, which is designed for the ethmoid and frontal sinuses; and the contour, which is designed for the maxillary and frontal sinuses. There have been a number of high-quality, double-blinded, placebo-controlled RCTs that demonstrate improvement in clinical outcomes with PROPEL use. It's important to note that these comparisons have all been done versus placebo. Now, SINUVA is another long-term steroid-eluting sinus implant. It's FDA approved for recurrent CRS with polyps in the setting of prior ethmoid sinus surgery as an alternative to revision surgery. So it's designed to be placed in the clinic setting. Now, similar to PROPEL, there are high-quality, double-blinded, placebo-controlled RCTs that demonstrate improvement in clinical outcomes consistently with SINUVA use. Now, again, these studies are done in comparison to a placebo. So some takeaways. The currently available literature regarding steroid sinus implants, although largely funded by the device companies themselves, has demonstrated consistently at a high evidence level that absorbable steroid-eluting sinus implants can be beneficial, particularly in the frontal sinus, which is more limited penetration via conventional topical sprays and rinses, and a tendency towards unfavorable scarring. These implants, however, not only carry a substantial cost, but also have an unknown impact on long-term patient-reported quality of life. So thus, the main question is, at this point, which patients stand to benefit enough that their outcome improvement outweighs the associated cost? Now, the patient characteristics and methodological details of existing studies are quite heterogeneous, varying, for example, in disease severity, extent of surgical dissection, and perioperative medical therapy, making it really difficult to identify cases where implants have the greatest benefit. Now, there is overall a general consensus that these implants have little utility in routine cases of CRS that have a low likelihood of recurrence or scar formation. But patients with poor compliance, more severe disease, such as aspirin-exacerbated respiratory disease, or relative contraindications to oral steroids, such as diabetes, these patients may have a more favorable risk/cost benefit profile, but more research is definitely needed. Additionally, the impact on patient-reported outcomes in these contexts and the role of these implants in the wake of newer therapies, such as biologics, also needs to be investigated. Now, for the time being, clinicians should carefully consider these treatment options on a case-by-case basis, taking into account each patient's unique characteristics and practicing shared decision-making. In sum, ICAR has concluded that at this point, these implants are an option in a previously operated ethmoid cavity with recurrent polyps. In the postoperative period, there is a recommendation for use in select patients with CRS and/or nasal polyps. As I alluded to before, the etiology of CRS is now believed to be primarily inflammatory. But do some exacerbations have an infectious component? Now, determining this is tricky and not agreed upon. In its simplest form, purulent discharge, as seen in the photo on the left, may be more infectious, whereas polypoid edema, as seen in the photo on the right, may be more inflammatory. It is also possible that exacerbations may have an element of both. For exacerbations with an infectious component, topical anti-infectives have been studied to see if they have a role. So I'll be covering the topical anti-infective data for both CRS without and CRS with polyps together, as the existing data does not currently or does not typically distinguish between the two. So multiple RCTs and systematic reviews have examined topical antibiotics in CRS, primarily in the postoperative setting, and have failed to show any benefit, and overall have recommended against their use because of a lack of evidence. In ICAR, topical antibiotics are not recommended in routine CRS. They may be beneficial in unusual circumstances, for example, as an alternative to intravenous therapy for infections caused by organisms resistant to oral antibiotics. And there have been some case series that have reported a benefit in recalcitrant or challenging cases, indicating that there may be a role for topical antibiotics in these particular cases, ideally in a culture-directed fashion. Now, to introduce the topical alternative therapies, it is important to discuss bacterial biofilms. Certain pathogenic bacteria, particularly Staphylococcus aureus and Pseudomonas aeruginosa, which are the most common bacteria found in recalcitrant CRS cases, these bacteria have the ability to form biofilms, which are well-organized structures of bacterial communities encased in a self-produced polymeric matrix that can tightly adhere to the sinonasal mucosa. These biofilms may contribute to recalcitrant disease, and several topical alternative therapies have emerged to target these biofilms. Now, surfactants are a type of topical alternative therapy. They include soaps and shampoos, which are both hydrophobic and hydrophilic. Their mechanism of action includes a mucoactive component, which inhibits and breaks up biofilms, and an antimicrobial component that elicits cell membrane disruption and loss of function. ICAR states there is limited data on the use of surfactants in CRS and provides no recommendation on their use. Manuka honey attacks biofilms and has a broad microbiological profile, most notably against Pseudomonas. Now, in vitro data was quite promising, but subsequently 2 RCTs have showed no difference in clinical outcomes. Now, ICAR states that there is limited data regarding the use of Manuka honey in CRS and provides no recommendation on its use. Another topical alternative therapy is colloidal silver. This is also antimicrobial and inhibits biofilms. 2 randomized controlled trials have demonstrated no differences in clinical outcomes, and ICAR does not recommend its use. Xylitol is another type of topical alternative therapy. It works by enhancing the activity of innate immune factors present in respiratory secretions. And the in vitro data has overall been favorable. And 2 subsequent randomized controlled trials have demonstrated limited, significant symptom benefit. So based on this, ICAR states that topical xylitol is an option for the treatment of CRS. Another alternative therapy is topical capsaicin. So capsaicin is an active ingredient in chili peppers, and produces a burning sensation on contact with tissues. Now, its mechanism of action is believed to be the degeneration of unmyelinated sensory C fibers of the nasal mucosa, which in turn downregulates sensory neuropeptide release, subsequently inhibiting mucosal proliferation and hypertrophy of the mucosa that contributes to polyp formation. 2 randomized controlled trials have shown improvement in clinical outcomes. And ICAR states that it is an option as an adjunct treatment. Regarding topical furosemide, there are no well-designed studies. Now, topical probiotics are the newest and potentially hottest area of topical therapy study, the goal being to restore the commensal sinonasal microbiome. Now, only 2 clinical trials have been done in CRS thus far. One study gave patients 6 months of Enterococcus faecalis nasal drops and found a reduced frequency of sinus exacerbations. Another study gave patients 2 weeks of honeybee lactic acid bacteria nasal spray and found no differences in clinical outcomes. Future clinical trials are definitely needed in this area. So overall conclusions. This table summarizes the ICAR recommendations for each of the different topical therapies we've discussed. For topical saline therapy, it is recommended in CRS without polyps and an option in CRS with polyps. For topical steroid sprays, so the standard delivery method, these are an option in CRS without polyps and recommended in CRS with polyps, with a consideration for twice daily dosing. For the non-standard delivery method of topical steroids, irrigations, exhalation delivery, and atomization methods are all an option in CRS without polyps. In CRS with polyps, irrigations and atomization are recommended, with the exhalation delivery method an option. With the topical steroid delivery method of sinus implants, these are an option in CRS without polyps during and after surgery, and recommended in select patients with CRS during or after surgery in CRS with polyps. Topical antibiotics are not recommended in either CRS without or CRS with polyps. And topical colloidal silver, xylitol, and capsaicin are all options in CRS without and CRS with polyps. So key points from this talk. Topical therapy can achieve high local concentrations with minimal systemic absorption, and it's optimally delivered at a high volume in surgically open sinuses in the head down and forward position. Topical saline therapy is recommended in CRS without polyps. Topical steroid sprays are recommended in CRS with polyps. And topical steroid irrigations are recommended postoperatively in CRS without polyps. And irrigations and atomization are recommended in CRS with polyps. Topical antibiotics are not recommended in the treatment of CRS. And topical colloidal silver, xylitol, and capsaicin are all options in the treatment of CRS. Suggested reading is listed here. I like to point out the International Consensus Statement on Allergy and Rhinology, 2021. This additionally is a review article looking at topical irrigations for chronic rhinosinusitis, the second bullet point. And the third discusses the potential, the third suggested reading discusses the potential for topical probiotic treatment for CRS, which is an interesting article. And these are my sources with additional potential suggested reading. Thank you.